Commonwealth Trade and Investment Summit. I'm glad that about 1,000 of you who've actually registered to watch this online, and we hope many of those will be following this particular session. Just to remind, we conceived of this summit when the Commonwealth Heads of Government meeting and the Commonwealth Business Forum, which we organise, were postponed for the second time in June 2021. For those of you who don't know, the CBF, the Commonwealth Business Forum, is the Commonwealth's most important platform for business to government engagement. It's a space where business leaders can meet with heads of government and other government leaders for dialogue on trade and investment, business and economic issues. CBF now hasn't met because of the pandemic since 2018, and while in no sense is this intended to be a replacement, we thought it was critical to convene a representative group of leaders to discuss the issues which are so vital to the Commonwealth business community as the world has changed so much since 2018. It goes without saying that these are unprecedented times, with businesses and governments around the globe managing through the challenges of the pandemic over the past 18 months. Our thoughts and prayers are with those who are still affected by COVID-19. The global economy and the economic recovery from COVID-19 requires a collective effort. And over the next 2 days, we will explore how member nations can leverage their Commonwealth connections to support their respective economic recoveries. While some countries, such as the UK, are making strong progress in recovery and emerging from this pandemic, many Commonwealth countries are still in the thick of it, with small percentages of the population vaccinated. Global recovery from this pandemic relies on worldwide levels of vaccination and uptake. So this session is designed to look at what's been successful in countries further along the recovery route and discuss how these successes could be applied to countries that have still further to go to improve outcome and to speed up recovery, and also look at lessons that we can learn in order that we can prevent some of the things happening if we see another pandemic in the future. I'm delighted to be joined by an extremely distinguished panel this afternoon. First of all, we have from what looks like his car, so he's a very mobile contributor to our efforts this afternoon, Professor Misaki Wayengera of Uganda's Uganda's COVID Responses Unit. Welcome to you. We have the Honourable Samantha Sacramento. Samantha is the Minister for Justice, Equality, Health and Care for the Government of Gibraltar. Gibraltar was one of the first countries to complete its vaccination programme and to reopen, and we look forward to hearing of your experiences. Gibraltar, I should say, is also one of our CWIC hub countries, so if you are interested in learning more about doing business in Gibraltar, please let the CWIC team know. Frank Hester, the founder and CEO of TPP, a CWIC strategic partner and a global leader in capturing, managing and analysing medical data. We look forward to hearing how, as the first pandemic in the digital age, he's been and his team have been combating the virus through big data and what we need to improve its effectiveness going forward. And Professor Richard Hobbs, the head of department and Nuffield Professor, Primary Care Health Sciences at the University of Oxford. Professor Hobbs has spent the last 18 months retasking his world-leading department to tackle the challenges of COVID-19. And last but by no means least, Baroness Neville Rolfe, the Chair of Crown Agents. We also welcome Crown Agents as one of our newest strategic partners. They're a not-for-profit international development company represented today by their chair. Crown Agents has been extremely successful and extremely busy on the front lines of the global effort against COVID-19, procuring and delivering PPE and vaccines to governments across the world. Crown Agents is currently contracted to supply over 37 million doses of Pfizer, Covishield, Covovax and Sinovac vaccines. Look forward to hearing Lucy's insights of how Crown Agents have overcome many of the unexpected challenges in the rollout of the vaccine. Before we begin, for those of you who are new to CWIC, I'd remind you we're a not-for-profit membership organisation. We work on behalf of all our members providing bespoke services, and we're confident we can open new opportunities and new markets for you right across the Commonwealth, especially as the world economy rebounds. If you want to know more about our organisation, please don't hesitate to reach out to one of our team. A little bit of housekeeping. We've started a little bit late, so we may go into a bit of injury time at the end, but the meeting will start with a 2-minute opening remarks from the panellists. Following that, there'll be a question and answer session. Please send in your questions for the panel via the chat feature, and I will put them to the panellists, or as many as I can. And before I begin, can I implore our speakers to limit their remarks to the allocated 2 minutes. So to start off with, I'm going to ask, if he's still with us, Professor Wanjera from Uganda to give us a 2-minute opening remark. Well, while we're waiting for the professor, who was in a car, to re-establish communications, I'm going to ask the Minister from Gibraltar, Samantha Sacramento, if she would give us 2 minutes. Minister. Minister Sacramento, if you could give us your 2 minutes opening remarks, please. I don't think she's listening, not hearing us. Lucy, can you hear us? Baroness Neville-Rolfe? Can any of the panellists who can hear us raise their hand? Yep. You all can hear us, right. Okay. Say again, can I ask Samantha Sacramento to give us her 2 minutes opening remarks, please?
Hello, good afternoon, everyone. Thank you very much for the invitation. I am joining you from Gibraltar to give you the perspective of our little nation with a population of 32,000 people and 14,000 frontier workers, and how we've had to completely change the way that we work to be able to deal with the pandemic. And also, we have, given that in Gibraltar things are relatively back to normal, we have also restarted the way that we offer healthcare and change things dramatically. If we can turn back to the week of, let's say, March of now, of last year, which I think is a far distant memory for all of us, because this has been the strangest year for everyone. We had our own specific problems in Gibraltar because of our population density. Although we're a small place, we were described as a raging fire by a dry bush. And that's pretty much what we were exposed to. And we went into lockdown very, very quickly. And as a result of that, our first wave during COVID was quite controlled. And we never had any deaths last year. Our deaths happened when we had our second wave towards the end of last year and in January. And that then coincided with the receipt of our Pfizer vaccine, which was provided to us by the UK government as part of the Overseas Territories Programme, and which we have called Operation Freedom. And we are the country with the highest vaccine take-up in the world. Obviously, as I said when I started, it's all relative because we are small. But because we are small, I think that we've been able to mobilize during the pandemic and to get us out of the pandemic in the best way that we could. Being small brought its own complications. At the beginning, we had tremendous trouble recruiting the staff that we need to deal with the surge and with the demands that COVID had. But during the course of the year, we set up our own Nightingale Hospital at the very beginning. And by the end of this, when we started, we couldn't test for COVID. We didn't know where to send our tests. Now we have a COVID lab that not only deals with processing COVID swabs, but we've also developed a genomic testing lab. So we no longer need to rely on the UK for things like that. So I hope that I've been able to encapsulate in the 2-minute period a little snapshot from this side of the world, and I'm happy to take questions later on during the session. Thank you.
Well, thank you very much indeed, Minister. Now we've got connectivity re-established with Uganda. I'm going to go to the Professor, Professor Warangira, to ask him for his 2 minutes.
Okay, thank you so much for hosting me, and apologies that I'm located in a place which is mobile. I was on the road when I got this invitation to join the meeting on behalf of the minister. Well, Uganda, of course, has had quite both terrible moment around this time in terms of the challenges to our health care capacity, but as well, of course, demonstrated some level of success in terms of prolonging and making sure that we prevent the spread of COVID as much as possible. We had our first imported case happening around March 21st last year. And of course, that was followed by the harsh measures of having to lock down the airport, the ports of entry, as well as making sure that we reduce on the activities that were being run in the interim. But during this period, of course, we made sure that we try to build capacity for not only case management, but also capacity for diagnosis, capacity for surveillance, capacity for community engagement and risk communication. And during this period, we've been able to do quite several things. We had, like I think the Prime Minister the Minister just came off saying they had one lab. We had one lab initially testing for COVID. That's the Uganda Virus Research Institute. But we managed to decentralize the testing. We brought in several parties to do testing. I think we have close to 15 public laboratories and more than 15 private facilities testing for COVID-19 currently. So Uganda has just come out of its second wave. And this is exactly why I'm trying to say that we've tried so heavily to prevent the spread of COVID. The initial measures enabled us really to stay the importation of cases and, of course, the build-up of the community spread for close to 4 to 6 months. And then, of course, we had to open up the country because we couldn't leave it closed for a long time. And in the process, of course, we progressed from the sporadic cases and then finally to community, well-established community transmission. But despite
Professor,
that,
I'm going to cut you in there, Professor. Cut in, I'm afraid. I know there will be lots of questions for you later on in this session, but I'm going to move now to Frank Hester.
Thank you, Professor. Hi, my name is Frank Hester. I'm the CEO and founder of a private company called TPP. And we're best known for our electronic health records across the world, but we started in the UK, where we've got about 9,000 GP hospitals and clinics, etc. And there's a little over 50 million patient records on our system. In the UK at the moment, 40 million COVID vax recorded. Why is that interesting? Because I'm not working in the Ministry of Health. I'm a private organisation, but it's really important that we get that data to for us, the UK, so they can help make decisions on what's going on. And, right from the start, we were working on trying to work out how this virus was spreading, who was getting it first, what what sort of people was it hitting, early? I mean, I think we all knew early on that it was affecting the elderly, but I think I would just say the importance of having what we call big data allow you to move very quickly from having an anecdote or a hypothesis to real evidence-based guidance for your populations. And, for example, we were able to quickly work out ibuprofen, working with, Oxford University and the London School of Tropical Hygiene and Tropical Medicine. Professor Hobbs is going to be on in a second. That inhalers were safe, ibuprofen was safe. And I think if I sum up, I think one of the key things for the next time, and we obviously don't want to have another breakout of anything whatsoever, but it's being able to ask flexible questions. And if only we'd had people's occupations on our database or their method of travel to work, we could have got to certain solutions a lot quicker. And that's what I'll be looking for next time and trying to share that sort of knowledge throughout the Commonwealth. Thank you.
Thank you very much indeed, Frank Hester. And now, Professor Richard Hobbs.
Thank you very much. I have just a few slides, if you can share them, or do you want me to just speak? No, I don't get a reply, so I assume that's not possible. I'm just going to briefly talk about the vaccines, which is, to be honest, one of extraordinary scientific achievement. It normally would take between 5 and 10 years to develop a novel vaccine. But in fact, the first vaccine against COVID was developed so quickly that it was in humans within 104 days of the origins of the virus in Wuhan, which is an extraordinary achievement. And that was partly because very early on, the Chinese fortunately released the genetic code for the virus. That was in late January, and that enabled the research teams around the globe to start to think about how they could produce a successful vaccine. Multiple groups did this. We in Oxford actually were the first to develop a vaccine in humans using a viral non-replicating vaccine. The first actually to get licensed was a novel RNA vaccine. And the extraordinary thing about the pandemic is that there have been 63 candidate vaccines developed over the last 18 months. Some of them are entirely novel technology. The RNA vaccines had never been developed previously. And to everybody's surprise, to be honest, not only were many of these vaccines successful, but they were actually more successful in terms of both reducing the likelihood of catching COVID, but much more importantly, reducing the impact of COVID in terms of death and hospitalization than anybody might have anticipated. So what we have is multiple countries have embarked on vaccine programs, and those that have been successful at getting 85% of the population vaccinated have seen dramatic reductions in admissions to hospital and deaths associated with COVID. The new variants, unfortunately, have been more contagious, and the vaccines are less successful against the new variants, particularly Delta. But double vaccinated patients actually still get very good immune response, even to Delta, and the vaccines are holding up in terms of more serious outcomes. So that's been an incredible success story. Just a word about safety. Although these vaccines were developed incredibly quickly, we have now hundreds of millions of patient years of data, and using systems such as just been described, the routine clinical records, there have been a number of studies that have looked at the safety of these vaccines. There are, unfortunately, rare side effects, but that's what they are, extremely rare. So things like, for example, the thrombocytopenia and subsequent stroke associated with that occurring in 2 in a million people. The natural background rate of that is 1 in a million. So it is a very rare event. And if you get COVID, then it's 8 in a million. So it's much more likely to occur if you actually get COVID than if you get a vaccine. And I think this is going to be a big issue for us in all countries over the next immediate period, which is convincing the population that they are much safer having a vaccine than not, and if offered it, they should take it. And vaccine hesitancy, unfortunately, is on the increase, and I think is going to be an issue for many of us around the world going forward. Thank you.
Thank you, Professor Hobbs. Now, Baroness Neville-Rolfe.
I'm delighted to be on this distinguished panel because it gives me a chance to thank the Commonwealth Enterprise and Investment Council and you, Hugo, and my good friend Lord Marland for the wonderful work that you do in getting us together. And of course, the sad truth is that we're still in the middle of the COVID pandemic with 3% of Africans only vaccinated. I thought I'd just, from a Crown Agent's point of view, I'm the chair there, mention 3 practical lessons for the panel. First, prevent a single point of failure. Following the panic on PPE, the Vaccine Alliance and UNICEF have worked to bring stakeholders together through COVAX. However, the supply line was cut when the Serum Institute of India, which was COVAX's sole supplier at that time of AstraZeneca vaccine, was subject without warning to an export ban by the Indian government. So tens of millions of promised deliveries didn't turn up, which was frightening. So the lesson, I think, is to diversify the manufacturing base for vaccine. Second, dropping the vaccine off at the airport is only half the story. So we see footage of health ministers standing in front of pallets containing millions of doses. But it's vital to realise that this is only one step in the vaccination process. So it's a much bigger logistical challenge to distribute the temperature-controlled vaccine from, say, Juba in South Sudan, 250 miles to rural Rumbek, miles, than it is to fly 4,000 miles from London to Juba. So a vaccine's only been successfully delivered if it's been injected, and that's when we should count the doses. So you can't have a vaccine without a syringe, you can't have a syringe without a trained health worker. And then third lesson, no one health system is the same. So the pursuit of universal vaccination has been a unifying mission, trumping most others, but not all governments in the global south see the mission as singly as important, I think, in their eyes. It's comparable to HIV, malaria, and other fatal diseases. So if you're a farmer in rural Bangladesh, would you sacrifice a day's income to walk 15 miles to the nearest health centre for a jab when the disease might not be very serious? So 3 lessons, and Crown Agents, can provide expert help in all of these areas because the practical matters as well as the geopolitical.
Well, thank you very much indeed, Lucy, for that. And we've got some questions coming in from the audience. But before we turn to that, I want to ask Frank Hester. We heard a little bit there about the actual delivery of the vaccinations, but it's been a huge problem and continues to be one globally. What, in your view, are the solutions, and how can, critically, the private sector support government efforts right across the board? And is the Commonwealth the ideal platform to coordinate these efforts?
Well, I think the Commonwealth has got the possibility to be the most coordinated group of countries on the planet if we decide to do it. And I think it's a tremendous opportunity for us all. In terms of delivery of vaccines, that's a bit of an all-encompassing term, as we just heard. There's getting it on a plane, I think, which is the easier bit. And then, there's that whole journey of making sure people understand that they are safe. And I think a couple of the panelists have said that. And I think something in my line of work that we can help with are just getting those raw facts and figures out, just absolutely kosher. This is the percentage chance of this. This is the percentage chance of that. This is how many people have had this. This is how many people have suffered. And, try to pass that on to all the relevant governments and share that around the planet. And for me, that seems essential, sharing real data.
Okay, thank you. Richard Hobbs, you said something earlier about the slight dropping off in the amount of vaccinations, and I think I'm right in saying that you said it was critical to maintain the levels of vaccination globally. But we've been suffering from a lot of misinformation and fake news, and that's certainly, I think, affecting the rollout of the vaccination in some areas. What impact has fake news and misinformation had on vaccine take-up? And more importantly, what can be done to counter it?
Well, it is having an effect, and I'm glad you raised this question of fake news, because, to be honest, it's been absolutely extraordinary this last 18 months about how well people from very different backgrounds, from very different countries across this planet, have actually rallied around a global pandemic, which could have been an absolute disaster for this world for the next 10 to 20 years, and have rallied around in a way that has actually brought things to a position where, although I completely agree with what Baroness has said, it's not over yet. We're in the midst still of the pandemic. We are learning to live with it, and that's a critical factor for humans on the planet. And yet, we are also surrounded by a huge amount of disinformation and vested interest for really bizarre reasons in disrupting the way that governments and people around the world respond to this crisis. And unfortunately, fake news does affect the way people perceive risk and balance. And it is affecting. And unfortunately, it's also disproportionately affecting groups. So there are ethnic differences in uptake of vaccines currently, and that isn't improving. There are economic variations between people as well. And we do have to consider how we respond to this, because we've done actually pretty well in countries that have had access to the vaccine. That's an important point to make as well. Some countries really have not had the access that they require. But even in the countries with good access, their rates of acceptance are declining. And it isn't going to be a one-off vaccination program. It'll need to be a repeated vaccination program, and clearly maintaining high population proportion of acceptance to offer is going to be key if we're going to try and bring things back to some semblance of more normality sooner rather than later. There's no easy answer, no magic bullet to this, but we all have our part to play. And I think that we need to start testing ways of actually increasing acceptance of the vaccine amongst groups that currently are either declining it or are uncertain as to whether to take it or not.
Professor Wangari, you're the chairman of Uganda's COVID responses unit. Are you beginning to come up against some resistance in Uganda in terms of the vaccination program? And if so, how are you countering that? I think we've lost the professor again. I think we've got a dicey connection with Uganda. Well, I want to ask, in that case, I don't want to ask that question of Gibraltar, because I think Gibraltar has had different experiences. But what I want to ask Minister Sacramento is about the government role. You were very quick in your remarks to say effectively what a success it's been in Gibraltar. But even in Gibraltar, how do you manage the public health infrastructure and the messaging, the educational outreach, the collaboration with the private sector, and the coordination? And what lessons have you drawn from the way you and your administration have handled it, if there is to be another similar pandemic in the future?
Okay, well, I think initially at the outset, the advantage was that we had a public health director who told us in no uncertain terms what was coming. And to put it into context, I think that when we had our first meeting in relation to the pandemic in January, very few people took that advice seriously, and everyone was quite skeptical. But we were very much involved in monitoring the progress around the world. And if we all recall what the position was when the whole pandemic started. Advice was changing pretty much, not even on a daily basis, on some days even on an hourly basis. And it was a question of everybody learning together, and us in Little Gibraltar were just monitoring what everyone was doing. But when it came to the government involvement in taking Gibraltar during the pandemic, I'm also the minister with responsibility for civil contingencies. So, of course, this became a civil contingency matter, and we set up a civil contingency structure where we had a top tier final decision-making group, which was chaired by our chief minister and deputy chief minister and His Excellency the Governor and myself as Minister for Civil Contingencies. And then I chaired sort of the next tier below that, which was our Civil Contingencies COVID Strategic Coordinating Group, which at the time was meeting pretty much on a daily basis. And in that group, the people on that group were the heads of all the relevant stakeholder departments. And the advice, predominantly from our Director of Public Health, but not exclusively, was discussed round a table in a room on a daily basis. And that is why I think we were able to control the situation as we did here. Remember that for us, it was a particularly difficult situation because we have a frontier with Spain. We rely heavily on cross-border workers. The majority of our cross-border workers work in our health and public and our health and care sector. And there was no question of that border not remaining open. For a while, Spain had restrictions, but it didn't affect our frontier workers in Gibraltar because of the reason for them coming into Gibraltar. But I think that the magic sort of that we take away from this is that we were all working extremely closely together, from government ministers to officials and heads of department, and our communication between each other was seamless, as was our communication with the public. In the same way as in the UK, you had your daily press conferences, we had our daily press conferences here. Obviously, because we were in lockdown and there was little to do, everyone was waiting for our 4 p.m. press conferences to get an update on the situation. And you know, if we look back, the situation was evolving so quickly that there was always progress to report on a daily basis.
How many daily movements are there, for instance, from La Linea to Gibraltar and back again?
We have, excuse me, we have 14,000 frontier workers. So that is pretty much guaranteed movement on a daily basis. Now, our frontier workers will predominantly work in health and care and also in hospitality. So whereas during the lockdown, those in hospitality would not have been crossing over, they are crossing over now, which is why our frontier workers also became part of our vaccination program, because they are so much part of our population for the purposes of us wanting to achieve population immunity.
Thank you. Lucy Neville-Rolfe, you were very clear about the role of Crown agents and particularly the logistical challenges that you've experienced in delivering vaccines, particularly the last mile, as it were. But clearly there is asymmetry around the world, and the view that unless the world is vaccinated, we're all unvaccinated. In terms of those of us who want to travel, and we all know we're having this session now because we can't actually still physically see each other, even within the 54 countries of the Commonwealth. But what more can we do, one, in the present climate, to ensure there is still greater rollout than there has been in some of the less developed countries, and secondly, to make sure that in any future pandemic, we don't have this slack take-up, which has caused so many problems and created an asymmetric world?
Well, I think in the short term, Hugo, we need to support COVAX and the work that it's doing, and encourage, the leaders of the world to continue to provide vaccines for some of the poorest countries in the world, which I think they've been doing, and that is good. I mean, for the future, my own feeling is that it is very important, picks up the fake news point actually, to have better education so people learn about pandemics in school, and they know that vaccines are safe. You know, the stuff we had, this drinking disinfectant won't work. You know, vaccines don't have microchips, don't put microchips into your body. We do need to change that, I think. And we found when we did Ebola in West Africa, that working with the trusted figures in the community made a huge difference. And I think that's very important. I mean, I think one of the things about COVID was, it, as somebody said earlier, it mainly affected the older people. Clearly, if you've got a future pandemic, we might not be so lucky. And, you know, there might be, and therefore that might be very much more serious in some of the Commonwealth countries.
Well, thank you very much for that. Coming back to something that Richard Hobbs said earlier, which is something that none of us should forget, which is the astonishing speed with which the vaccine was developed and then people were first vaccinated, which I think is, I'm right in saying, breaks all known medical records. But we are now talking, particularly here in the UK, about vaccinating much younger people. Indeed, we're talking about a third booster vaccination now in the autumn. And yet there are those countries, sorry to labour the point again, around the world, who are still struggling with their first vaccinations. And surely this, as I've described it, this asymmetry is not in anyone's best interests.
No, I mean, I completely agree with you, Hugo. I think that this is a challenge to us, is that we've got marked asymmetry now around vaccination. I mean, the other aspect of education, though, I think before I turn to that point, we should remind ourselves about, though, is it isn't just about vaccination. All the public health measures that have been shown to be successful during the pandemic need to be maintained if during waves, and that includes simple things like masks. Masks don't have a huge efficacy, but they have some efficacy, and they are so simple that we wear masks to protect others, principally, not ourselves, and therefore it's a sort of human response to actually want to protect other people. We need to be sensible about not spreading ourselves around if we become symptomatic or we're at risk of becoming symptomatic. The lockdowns have been spectacularly successful, frankly, which has meant that during the first two waves, most infections that occurred in countries that were able to accurately measure this were within households. They weren't in the workplace, they weren't in schools, they were in households or in residential environments with high proportions of COVID, such as hospitals or nursing homes. That's probably going to change because people now are relaxing. They're not actually doing sensible public health measures. They're not wearing masks, even in public. They're not necessarily even quarantining themselves when they get symptoms. And I think that's got to be as maintained as a response to vaccines. But I think you raised an important ethical point, which is alongside considering how you bring things under control within each country, we do need to think about the wider world, because otherwise all we're going to do is enable the proliferation of new variants. And of course, new variants may bite back even those countries that bring things under control for the current variants. So there is an imperative, both morally, but actually scientifically as well, as to try and bring most countries' waves under control.
Frank Hester, you talked earlier about the data collection, the analysis, and that all being critical in the continuing fight against COVID-19. How much time are you spending, or is your company spending, analysing the available data now, and how much time are you spending trying to share that data with some of the developing countries?
Well, I think for me, for about a year, it was full on. We didn't do anything other than, I think from about, God, I can't remember the year. From just after we found out it was going on in Wuhan, from that February onwards for about a year, and then not so much now because I think people have got more information themselves. But I think there is a problem talking about big data and talking about AI in that, well, everybody's got it and everybody's doing it and everybody's selling it. But I'm telling you, in healthcare, and I say to the government listening to this, get your big data, get your AI. It's so useful. We were using it for early detection of cancers before COVID, and then we actually used it to mine the doctor's notes. We were able to see the anosmia, lack of taste and smell. That was going on in the UK well in early January. The pandemic was obviously up and alive, and you could see it, and we just didn't know it. And I think especially with the kind of big data, and it's all very doable now as well. Like years ago, that was a hard thing, but it's you can, unless you're China or India, where you're trying to do a billion, you break it down by province and state. Pretty much the rest of us can do it fairly straightforwardly, and it can give you clues to your country and help you move forward in ways that you can't. But we're still communicating, we're still doing it, but not night and day, so to speak, now. So I think the vaccine has helped us relax.
Richard Hobbs, you want to come in at this point, I think.
Yeah, I mean, I think one of the accelerated successes during the pandemic has actually been the recognition that health systems and countries do need to invest more in digital health. And not just for the data, although it has been incredibly important, but because it enables the health system to actually reconfigure the way it provides care more quickly. And so what we've seen over the last 12 months is an absolute transformation in the ability of patients to access some healthcare even during the most strict lockdown, and that's through video consulting and access to even remote bloods has been possible. Now, it is true to say that much of this has been piloted in well-developed health systems like in the UK, but they are transferable. And I think in the long term, this is going to be incredibly important, because what we've been showing, for example, is the ability of people to self-manage their conditions better, digitally enabled, so that if you're in some rural community somewhere where it's a day's walk to get to a health centre, the potential for you to able to be more accurately monitor your blood pressure if you're a lady and you're pregnant and your blood pressure is not well controlled, the ability for you to be able to do that and interface with a healthcare digitally is, I think, is going to become increasingly important. So just like most aspects of our lives, where we travel, where we access financial services, where we shop even, is very digitally enabled. Healthcare currently in virtually every country is very limited in its digital enablement. I think that needs to be transformed as well. And there are lessons, I think, for all of us around the Commonwealth in how we can do that more effectively.
Minister Sacramento, it doesn't take a day to go to a hospital or a health centre in Gibraltar. So in that sense, you're atypical. But do you think there are lessons that Gibraltar and other of the smaller Commonwealth countries can actually hold up as exemplars and export as best practice to other Commonwealth countries? And if so, what are those?
Yes, I think like everyone else, we have learned a lot of lessons. And because I form part of the Commonwealth Parliamentarian Association, during the course of the pandemic, I've been in close contact with my counterparts in other Commonwealth parliaments who've been dealing with this, and we've been sharing a lot of information. I recall at the beginning when the whole pandemic started, I'd just returned from a conference at the Falkland Islands, and I was in touch with one of the members of the government in the Falkland Islands, who is himself a doctor, and we were just helping each other in terms of how we were going to undertake testing. And obviously, you know, at the time it was very difficult for us because there was no way that we could test the COVID swabs here at the outset. But it was that much more difficult in other Commonwealth territories that are even more remote than we are. I think that overall, and without going into technical detail, overall what the pandemic has shown is, I think it's shone a spotlight on health and care professionals. I don't think that nurses and doctors and non-qualified nursing staff have ever had the recognition that they deserve until they've been there for everyone during the pandemic. So I think that that is a huge positive for people in that profession. But as you know, other things that we've mentioned, data, we weren't very good at collating data. And now we are improving our electronic medical records. We have now set up, because of our surveillance COVID testing, and because literally we had to mobilize and get everything into order, we now, that when we started testing, and particularly then when we started vaccinating, because we had such a high demand for the vaccines, it made us realize how inaccurate our medical records were, our database of patients was, because in Gibraltar we have one hospital, one primary care provider, and one database. But it just showed us how bad that database was. So when that came to our attention initially through the swabbing exercise, we had to make sure that we had it absolutely right for the time when we were receiving the vaccines, to make sure that we were, and even then we weren't. So we were having, you know, that exercise being done over and over again, and now hoping that if we are going to administer the boosters, that, you know, third time lucky and we'll get it right then. But data has been so crucial. And now going forward, and I want to talk a bit about the genomic testing that we've been doing, because initially, once we set up our COVID lab, we then wanted to take it up a level and do the genomic testing, because we were sending our testing to the UK. But that meant that we had to wait in the queue with everybody else, and we were not getting our results for about 3 months, in which case, you know, by the time we got the results on the variants, it was probably too late for anyone to be able to advise us on which decisions to take. So we set up our COVID genetic area in our COVID lab. And now looking forward in terms of lessons learned, you know, the genomic testing has proved to be so invaluable that we want to undertake genomic testing generally, so that it can inform us in our health strategies going forward. So I think if we look at every single thing that we've had to set up for COVID, we can probably use that as a lesson to develop going forward. Because of our, I think the only way to describe it is our heightened stress. Heightened stress during the pandemic gave us heightened focus. So we had to get it right, and we had no other choice. And now that we've pretty much, you know, put all our resources into improving things, we've got to make sure that we capture the best lessons from COVID and continue to apply them going forward.
So this genomic testing, are you aware that other countries have done that in the same way you have? Perhaps I'll bring in you and Frank Hester on this. And is this, it's one of the exemplars, how do you intend to illustrate and demonstrate and indeed evangelate as to what you've done successfully to other countries, particularly within the Commonwealth?
Okay, shall I go first? Well, in terms of our lab, I know that we're already in contact with other labs in the UK so that we can collaborate in terms of the data that we receive, and we will become part of the information bank of the genomic of the COVID genomic testing. And now we're looking to see how we develop that and take that to the next level more generically in terms of genomic testing.
Thank you. Frank, do you think the genomic testing, data collection, all that is something that you'll be looking at to coordinate going forward?
Yeah, I think certainly there's an opportunity for some countries who don't have an EMR, and I'm interested in that Gibraltar journey, that as you're doing it, you decided to improve it at the same time. because it is an opportunity when you're recording a vaccination against almost all of your citizens. Well, that's your opportunity for your EMR across the country. And I should really, I did mention it earlier on. So with Oxford University and the London School of Tropical Medicine, actually, Professor Hobbs, who's on this thing, has played a great part in that. Over 30 papers have come out about which have been published worldwide. But I should say that I think all the time I was trying to read papers out of other countries as well. That collaborative effort. Some of the early stuff that's came out of China really helped me try and work out how it was transmitting. So I suppose not just the Commonwealth, China and India. Sorry, I beg your pardon. I was going to say USA, not India. China and USA. I think there's just a tremendous opportunity for us to perhaps do better next time or not be so caught on that.
Thank you. I just want to ask, just to wrap up, Baroness Neville-Rolfe and Professor Hobbs, in just a few minutes each. We've been talking about vaccination, and at some stage, countries will be fully vaccinated, either with third booster vaccines or not. But this has been a world changer. It's not a cliche to say in terms of data collection, data sharing. We've made huge acceleration in data sharing, particularly in the NHS in the UK. But the world is going to change, is it not, because of what has happened over the last couple of years. So can each of you say what you think a world living with COVID or living with a pandemic is going to look like, and how that is going to alter our behaviour going forward? If I could start off with you, Lucy, and then ask Professor Hobbs to finish off.
I think the experience of COVID has obviously changed how people view pandemics, and therefore that will put health care systems and indeed investment in community health workers and so on up the agenda. I think it's been a big change. And clearly there's been a cost to the pandemic, which is obviously going to change, the wealth of different countries. I think the other thing that may be helpful from a business point of view is that it's been a good example of collaboration between the private sector and the government sector. And it's shown that the private sector is much more speedy. So the government, I think, can work, and Commonwealth and so on, can do things and respond effectively. But I don't think we would have had the vaccines that Pfizer and AstraZeneca and others produced at such speed if that hadn't been led by the private sector. So innovation is incredibly important on pandemics like this, as well as on healthcare more generally. And then we rightly spoke about data. So the knowing about and tracking data, I think, is going to become far more important. And there will therefore need to be investment in that. And then back to the private-public sector model, we've got the WHO who do good work, but they aren't necessarily able to respond at quite the speed. So I think there will be a different attitude both within, as it were, the health sector, but also amongst the world leaders.
Richard Hobbs, before you answer or add to that question, just something that Baroness Neville-Rolfe just raised. Does this alter the very long development times that pharmaceutical companies like to take in order to get a drug from conception through clinical trials into the body of the human at the end? I mean, it has been an astonishingly quick reaction to this pandemic. And if we can do it for a pandemic such as COVID-19, why can't we do it for other diseases? Does this blow the cover on these rather expensive long clinical trials? Can we get better and smarter at it?
Yeah, I mean, I think the simple answer to that is we can. There always have been mechanisms in place to register drugs more rapidly or give them limited registration more rapidly. That's true particularly of cancer, for example, where prognosis is poor. But what has been demonstrated here is that a willingness to to look at data rapidly. So, for example, the regulators were reviewing the data from all the vaccines very rapidly. As the data was coming in, they didn't wait until it was all done and then read it, which is one of the delays in the current system. So I think there are things you can do to speed up, and I'm sure we will see a lot of pressure to do that. I think it is a perfect example, frankly, where science has interfaced with need more rapidly than almost any circumstance outside war. Wars, unfortunately, often breed rapid innovations because of necessity. I think what the pandemic's shown is that it doesn't have to be a war environment. It is basically natural disasters are also opportunities for humans to collectively learn how they can interface more effectively in future. And I hope we will take these lessons away. We've heard quite a few things today about interface. I think actually the academic sector has been absolutely crucial. In fact, the vaccine development has largely been led by academics within universities. Many of the candidates were developed within university environments. Yes, they've had really successful, rapid partnerships with industry in terms of implementing that early evidence. But I think the university sector has been important. Commercial sector has been critical. Relationships between government, the way experts interface with government and government filter that expertise in a way that they can make decisions that they've been elected to do. I think all of those things are important lessons for us. We haven't got it all right. I think the testing has been a big issue, and countries working out how they can provide testing for a virus like COVID is important. We've heard about manufacturing. You cannot depend on single manufacturers. We need to think about that going forward and the way we transport things around. The genetics, I think, is going to be important. That would have been impossible even 5 years ago, because it would have just been economically impossible to genotype these numbers of samples. The reason is that science has actually now compressed the time it takes to read and massively reduced the cost. 20 years ago, it took years to sequence a full genome and cost tens of millions of dollars. And you can do it now in less than an hour, and for rates that continue to drop in price. So I think things like that are going to be important as well. And the reason why I feel somewhat optimistic about this is because we were talking earlier about the importance of global warming, which is obviously another mega important factor for the planet. And hopefully we're going to learn that partnerships between science, between governments, between commercial sector and the people that basically need to consider these matters, the great public on the planet, we are going to have to engineer solutions to other major problems as well as pandemics. And if we can solve it in future better for pandemics, hopefully that's going to spill over into some of these other global issues as well.
Well, thank you very much indeed for that elegant summary. Perhaps we haven't had enough of experts. I'm extremely grateful to the panel for taking part in this session. I'm sorry that our link with Uganda was temporarily interrupted, but I found that extraordinarily useful, and I hope all of those of you still listening in did. I apologize for overrunning a bit, but I did say at the outset we would have a bit of injury time. That concludes this session, but please join us for our next session, which begins at 2 o'clock this afternoon. That's UK time, and it's called, rather appositely, following on from what we've just heard, A Sustainable Future, Decarbonising the Economy and the Race for Renewables. This will be addressed by Samantha Cohen, our very own Chief Executive here at the Commonwealth Trade and Investment Council, the Honourable E.P. Chet Green, the Minister of Foreign Affairs, International Trade and Immigration, Antigua and Barbuda, His Excellency Mohamed Nasheed, a former president and currently the Speaker of the People's Majlis in the Maldives, Richard Abel, the Managing Director of UK Climate Investments LLP, and Madalena Kuniva, the Director General of the Renewable Energy Efficiency Partnership. If there's anything you've heard or learnt or want to question about the session we've just had, please get in touch with your local CWIC representative if you have one. If you haven't, there's one coming to a place near you soon. But otherwise, contact the team here in London and we can introduce you to each other, because I think what we've learnt from the session we've just had is that this is something we've got to learn with. There are lessons to live with. There are plenty of lessons to be learned. There's plenty of opportunity for cooperation between, in fact, it's inevitable and desirable for greater cooperation between the public and the private sector, and that should cross borders as well as cultures. Thank you very much indeed for joining us.
Thank you.
Thank you.
Hi, everyone.